All right. How are you kidding? Good night.
Hi, Ryan. Can you hear me? Hi, can you hear me? Hi, good morning. Hi, this is Drew. Can you hear me?
Oh, I think we'll be in good shape. Let me just.
Hi, good morning. This is Drew. Testing, testing. Jesus
Hi, is that better, Ryan?
And don't close it out.
Yeah, I don't know if it'll like cause a. That was weird.
I can hear you pretty good.
There's no reason this shouldn't be working.
Did you have this plugged in?
No.
Okay.
It's using HDMI. He's unmuted.
I can hear you. Can you hear me now? 'Cause I can hear you guys really well. Hmm.
Do we want to try to have him?
Unmute myself. Mute this.
Oh, maybe. Yeah.
But I feel like
Can you guys hear me?
it says he's talking. There's no
Yeah.
reason it shouldn't. It's showing audio levels for him. How do you adjust the room levels?
Oh, over on our. Do you want me
Yeah.
to turn it down?
Is it way up? I'm wondering if
It
he's just.
normally is way up for the mics.
Yeah.
Yeah, I was just gonna say like it must be down because the mics are not. Because they're not as loud. I turned it down when I heard that noise thing.
Yeah.
So.
But we could turn it back up. Maybe.
Okay.
Yeah. Okay.
Was it?
Yeah.
Okay. We might not be able to have too long.
So is it not working? No, it's just not working, and it should.
Just not working.
Yeah.
So we'll play this one.
Testing, testing, testing.
Is this on? Good morning, everyone. Welcome to Seattle and Cambria Grove. It's always good to use this space. I think it's a really nice thing that the Cambria Grove has made available to us and other groups in the community around good conversations, and that's what this is about today. I'm really excited about the agenda. There's been a lot of interesting work that has gone into getting ready for this, and it's all built on what we talked about as our last time together. And so I'd like to start there by giving us, reminding us of what that conversation was a couple months ago, and what has led to our conversation today. So last time we were together, oh, by the way, I'm Bill Robertson. I'm my privilege to be the co-chair with Sue Birch. So we agreed this year to advance an action agenda focusing on well-being. The idea that it's not just about care delivery or access to care, but it's about well-being of human beings. And there was a lot of interest and energy around focusing on well-being through the lens of equity as kind of the lens we take to well-being. We talked about equity as a foundation, and as a principle, we've been talking about equity as a foundation, a principle for many years. But it hasn't always been baked into the work that we've been doing. We've had other initiatives and other ways of looking at things. Today, we're going to aim to bridge from conceptual discussions about equity to taking concrete actions to advance and integrate equity into our work. So we're trying to go from idea to action is the agenda for today. We're getting there by understanding, first of all, the business case for focusing on health equity. There's, I think, a moral case, clearly an ethical and moral case for equity, but there's also a business case we're going to get to talk about today. That's today. And inviting the community to help shape this agenda. It isn't just about what we think, it's about how the community shapes an equity agenda that's relevant to them and relevant to where they start in this conversation. We hope that we're all going to leave the meeting today with a better understanding of why health equity is important and understanding how addressing health equity benefits our organizations from a business perspective. I think it benefits our organization from a lot more than just a business perspective, but at least from a business perspective, and understanding how we will advance health equity work individually and collectively. So we have individual responsibilities in this space, and I think we have collective responsibilities, organizational responsibilities. So there's a lot of good people in this room. There's some people on the phone as well. And it's important to know who's here. So we're going to take a couple minutes here. We go around and introduce ourselves. Since there are people online, if you're not using a microphone, they're not going to hear you. So we're going to have a microphone that goes around. And what I'd ask you to do is introduce yourself and the organization you're with. And we'll just pass the mic around. And I'm with Multi-Care Health System as I get paid for that. And I do stuff like this. So I'm going to start with this first table, and we're going to start with Sue, and she's going to introduce herself, and then we're going to go around.
Good morning, everybody. I'm Sue Birch. I'm the Director of the Healthcare Authority. Happy Friday.
Good morning, Anthony Chang, President at Empire Health Foundation.
Good morning, Josh Martin, CEO of Summit Pacific Medical Center.
Good morning, Tony Smith, Spokane Regional Health District.
Sybil Himmelstein with SEA Healthcare, 1199 Northwest. Regina Delahunt,
Whatcom County Health Department.
Good morning, I'm Corey Sparber, the acting CEO with Group Health Foundation.
I am
Doug United Health.
Good morning, Diane Sosney, SEIU Healthcare, 1199 Northwest.
Hi, Teresa Tabahiro, International PT Health Services.
Good morning, Aaron Sparks, Seattle Indian Health Board.
Good morning, I'm Joe with Isabel Health Services.
Good morning, my name is Maria Gibney. I'm with Healthier Here, the Accountable Communities of Health for King County.
Hello, my name is Amy Pritchett. I'm the Director of the Public Health Program at Washington Tech, but I'm here representing the Community and Consumer Work Voices Work Group Committee at Healthier Here.
Good morning, I'm Wilson Gellman from the Office of the Insurance Commissioner.
Good morning, I'm Janet Barron, Director of Northwest Law.
Good day, recently in Washington State Department of Health.
UN Washington Health Benefit Exchange.
Hi, I'm Diana Oates with
Arcora Foundation.
Good
morning, I'm Juan Alamos with the Washington State Healthcare Authority.
I'm Alan Cheadle with the Center for Community Health Evaluation at the Kaiser Research Institute.
Nancy Gento with the Washington Health Alliance. Laura Little, Executive Director of Cambia Grove.
Good morning, Jürgen Onup from the University of Washington and chair of the Department of Community Health Sciences there.
Hello, I'm Kate White.
Hello, I'm Kate White, I'm with the Washington Association of Community and Migrant Health Centers.
Ronnie Gate, Work Member Director of Community Civic Engagement as a Bill and the Gates Foundation.
Good morning, I'm Brenda Onabaro.
I'm the Learning and Engagement Manager at the Group Health Foundation. Good morning, I'm Danielle Commercial. I'm the General Counsel and Strategist at Health Benefit Exchange.
Good morning, James Sabowski with Washington State Labor and Industries.
Good morning, I'm John Bose, I'm the acting Administrator of Labor and Industries.
Hello, I'm Cal Health Manager, Health Equity at Community Health Plan Washington.
Bob Crittenden, here at Cambia Grove at times, and pleasure to be.
Regional Policy Division, Healthcare Authority.
Jason Napier, Policy Division, UCA.
Kennedy Swallow, Communications, Healthier Washington.
Mark Harpenstein, Health Safe Health.
We've had two people who missed the mic, so I'm going to come over here.
Hi, I'm Kathleen Paul from Virginia Mason. Good morning, Jason McGill from the Marines Policy Office.
So I'm not sure if it's all on the line. Do we have anyone on the line right now? We do. Okay, so we have people on the line, but we don't know who they are and we can't reach them. So we do know that we were trying to get Drew Martin, who's with the Institute for Health analyst of this program, and we've had some technical challenges. I'm not sure we're going to get him on the line in time for that. You guys hit me happy when he does that, when he gets online. So Health in Washington, it has three basic strategies that we're trying to drive towards, or we're going to use to drive towards a healthier Washington. So the three strategies are really straightforward: paying for value, ensuring wholesome care through the integration of physical and behavioral health, building healthier communities through clinical and community linkages. So that's kind of the framework of the work that we've been working on for several years here. There's multiple implementation mechanisms that have been at play in this space. We're in the final year of our Healthier Washington federal grant. We're just kicking off or just entered the 5-year Medicaid transformation grant that we have through the feds, and it's all supported through landmark legislation here in Washington that set the table for providing integration, experiencing community linkages. And we couldn't have set this ambitious path or executed on it without all of us working together. Sometimes we're pioneers. The difference between a pioneer and a settler is those who are breaking the way versus those who are setting themselves up. And we're pioneers in this. We're not yet settlers. We're not quite sure where we're going to end up in this journey that we're going. But it takes all of us thinking together to create a future healthier Washington. We can't advance the aims and strategies of healthier Washington while there are inequalities in the health system. We can make progress here and there, but really we're going to move it much faster if we can create, eliminate the inequalities in the healthcare system. Healthcare equity is a foundation principle that we're working from, but it hasn't always been the focus or the lens through which we're working on this. So we're in that transition now to use health equity as the lens that we're going to be focusing our work going forward. And we haven't been prescriptive at all in the health equity space. We think we will have the opportunity to move towards more of a prescriptive approach related to health equity. And we'd like things to be widespread, and measurable, and actionable. Good ideas that aren't actionable are just action results, and that's what we're to achieve. So you are a guide as the HILN members in applying equity through the organization and healthier Washington and communities in the greater community. They've been working with us to think about how we're going to create this. We have some program. We've had some interesting things going on in the region. There's interesting programs, and I'd like to give you a sense of some of the things that have happened actually since we last met and are at play here. There was a Washington State Nursing Act Coalition received a $90,000 Robert Wood Johnson Foundation Public Health Nursing Leadership Grant, name for a grant, to broaden the reach of their work, increase awareness and integration of social determinants of health. When you think about the role of a nurse, it is actually in the context of culture and those types of things, but we don't necessarily do a great job understanding that as we're taking care of someone. And the coalition is using this round of funding to continue building understanding support for nurses to use social determinants of health assessment and intervention in all care settings. It's an interesting lens for them to be working through. This includes building toolkits to explore opportunities to help nurses assess social determinants at the point of care. Nursing leadership students will hold focus groups to ask nurses who are in practice in practice, they benefit from asking questions from the core social determinants of health assessment tool at the point of care and identify barriers to implementing social determinants in their practice. This is an interesting study. The coalition's previous Robert Wood Johnson Foundation funded project, in collaboration with Healthier Washington, provided educational opportunities
for nurses in several practice settings, they made a significant change in their awareness of the importance of social determinants of health. So determinants being around education, employment, income for their patients. After participating in the learning, these nurses had 48% of them were able to respond in the survey about identifying the impact of these. In the pre-survey, only 29% were able to. So really almost double the percentage of people who understood how social determinants made a difference in this. Guided by the recommendations from the Communities in Health Equity Accelerated Committee, ACA worked on an approach to disaggregating the health plan data by race, ethnicity, and language using an inclusive methodology. So this is the second item. This is helping to scope potential areas and populations that may be ripe for monitoring and improvement by purchasers, health plans, and providers. So a little different lens had in the process. Also, King County hired previous employee wellness program. That may seem like a bad idea, except what they're doing is seeking to be much more relevant in their health plan to the specifics of an individual's transition to an equity-informed framework, co-designed wellness programs for King County employees more responsive to their interests, their needs, their culture, and they're planning a focus on health literacy, which it's interesting how health equity and health literacy relate in really interesting ways. And some prior work that I did outside the United States, we found that literacy itself and health were highly linked. So people are literacy challenges also affect healthcare or their health. Several state agencies are sending their staff and leadership teams to cultural competency training support staff, DOH, and ADA. Receive training through these recent 2-day workshops. We're hoping to bring a workshop to this group in the future. We'll all get to participate. That could be an interesting experience for us. Healthier Washington sought and received Robert Wood Johnson Foundation Institute for Health Improvement support to focus on Healthier Washington equity work. This effort aims to support HILN and the ACH's statewide cultural change work and community action work. More prescriptively, prescriptions may make sense. We do a lot of them in healthcare prescriptions. More prescriptively, integrate equity as health transformation continues. As we planned our meeting and consultation with many of you, and many of you are active participants in this day, but with the planning participants as well. We aim to mirror in the meeting agenda with the project proposal. We'll be advancing some elements of the proposed trajectory roadmap during the meeting today. The project summary is included in your meeting packet, and we'll be talking about this in more detail throughout the meeting. So, set up for the You're not going to have to listen to a story. I very much is going to be members of this group and others who are helping us lead us through interesting agenda. So it's my privilege today to introduce Bert to you, who she no longer needs introduction. That's you. She's going to sit down for part of the agenda.
Great. Thank you so much, Bill. This is really another exciting meeting because first off, we keep showing up. We're showing up for big numbers, and I love some of our folks that are returning to us and our new members coming. So thank you all for being here and for that setup. Thank you. Yesterday I had time with Joint Select Health Oversight Committee. That's a long name. But our legislators were really interested in our progress. And I think it's really important for us to whenever we can, to stop and kind of just remember where we are. We really want to celebrate too a lot of the accomplishments. So this is a long, arduous journey. I loved your settler. I played too much Catan. But we've got to stop and really just really recognize all that we've accomplished in this journey. So we really need you all to stop for a minute, have a moment, and breathe and really celebrate where we've come from and the accomplishments thus far. So take a breath. Guys, guess what? This commitment around how we keep moving forward really requires us to help to have this public-private partnership. And in order for us to really make sure this work endures and stays, we've got an ongoing journey. So we've got to be refreshed, and we've got to make certain that we've got the strength to keep going forward, and we will. We know that really this work is ambitious and far-reaching, and that all of us together, all the agencies, all the partners, all the folks can achieve this lasting transformation. But we really, really need echo messages, and we need to break it down. We really need this network that will ensure that we keep advancing for healthier Washington. So really critically important for us to also think about what are the key takeaways. We've agreed also to advance an action agenda to inspire this social transformation in Washington. And I think that the equity contribution that was just made in our state is really just the beginning of how we're really going to make sure that this work takes hold. I love hearing about King County and others that are going on to really drive towards equity resolution. So we're advancing on this journey with a focus on equity. And it's really important to make sure we understand the definition of equity. So on this slide, you'll see, and I am going to read it because I think it's really important, because I think we're going to have to hear this about 7 times, and we're going to have to keep breaking it down for people. And I loved yesterday, somebody brought up the difference between equity and equity. So let's just read this. Health equity is all people have the opportunity to attain their full health potential, and no one is disadvantaged. We will proactively pursue the elimination of health inequities and preventable differences in health among groups based on socioeconomic status, source of income, gender identity, sexual orientation, race and ethnicity, tribal membership, language, immigration status, age, religion, the job they have, education, disability, housing status, the neighborhood they live in, or any other socially determined circumstances. And I know that during our last quarterly meeting in April, we learned from you all really some great information applying equity in our organizations. We really had a productive discussion, and I keep encouraging the state. There's one thing I've learned sometimes is we're not okay with health contention, and I think it's good that we have gnarly stuff to chew on. We learned some great information and got feedback about how we had to go deeper into data and really the magnitude of the challenge. But the themes included all these areas: race, data, tactics to engage those who live, those with lived experiences, and social determinants like housing. So we are forming more of this work, but we've got an ongoing journey ahead of us. We absolutely walked away with the recognition that we as individuals and organizations are all in very different places when it comes to understanding and applying health equity. And that's okay. It's really okay. The fact that we are acknowledging and setting a course is really, really important. We've got great offers to help shape the next conversation, and you're going to be really thrilled about the one that's going to occur today. So I do want to thank some of our really outstanding leaders in the field, such as our Asian Counseling and Referral Service, our Northwest Health lawyers, and our International Community Health folks, and the Communities and Equity Accelerator team for co-championing this work and really kind of inspiring a deeper conversation. So I want to also, before we enter the panel, I want to recognize and invite some of the foundation leaders to really share their reflections and then discuss some of their thoughts. And I know you're going to be our, actually not yet. Aaron, where's Aaron? Aaron and I spent, we were in Ferndale, weren't we, Sunday and Monday, so we've been moving around, and then, but anyways, my point is that Aaron's gonna just talk a little bit too about some of his thoughts, because it's really been this advanced thinking help shape our work. Aaron.
Thank you. I'm actually going to put some notes down. I've been traveling so much, and like she said, last week I was in Oklahoma. One of the most interesting things I love to talk to everybody about it. I sit down with the first secretary of Homeland Security. which is really interesting because this is one of the 3 people who said it's okay to take children away from their parents and separate them. So we just sit in this room and talk about tribal emergency management. And I sit with her for 8 hours, and in the end, take a picture of her smiling. And when you do see this picture, I do want to I'm smiling really hard because I'm not so happy to be with him, although he was a very well-spoken. He cared about what we were doing. He read an 8-page issue sheet. He understood everything inside. Came prepared with real questions. At the same time, you still feel these things on the inside. I have this huge grin on my face because while I was there, one of the guys from Pinewood Reservation says, "Say government cheese," and I couldn't help but to smile. And it's like, so I have like, this is my best friend in the world right here. It's like a really big smile on my face. I'm pretty sure they're going to put that on their homepage. So I'm really excited today to talk about, because I'm part of the Community and Equity Accelerator Committee, about what we're trying to accomplish here. It really came out, we have some really good things from that last meeting. One of the big ones that we heard, Diane was about the need to address racism, being uncomfortable. But I'm really happy right now that we're at the place where we're talking about our accelerator committees doing something. And I know I was one of those people who voiced their frustration early on 3 or 4 meetings ago about, we've been here for 2 years, 55 very powerful people. The amount of moxie in this room for each of us to get to where we are is pretty amazing. It's immense at that point. If we really want to change something, we can do it. We've already done it in the small worlds that we're in, and I'd really like to see that in each of our accelerated committees, in each of our communities that we serve. So I'm happy that we're getting to the point where we're getting these concrete steps now. I want to really feel this. I want to get to the point where we're out of our heads and it's somewhat tactile. We're going out there and we're feeling it. We're seeing it. It's part of who we are and what we're doing. But also part of what we're doing today is we have to embrace discomfort. This is not easy. Whenever you're talking about equity in a situation like this, and I really do mean the state of Washington, we do tend to skew towards the culture in the state. Being a person of color, that's something that's extremely apparent. No matter any something like this, if you look around this room, it's apparent. But that's not something to be uncomfortable with. Embrace it. You can be uncomfortable with it, but embrace that discomfort. Talk about it. Share it with everybody around you, because if you're not going to do that, you're going to hold it in, and a lot of the very strange and odd issues that hurt a lot of us are not going to be brought out, and we're not going to be able to address them. So, and I do want to put out there, once we do these things, open ourselves up to understand really what equity is, we can innovate for our entire community at that point. We represent Medicaid, the demographics of that, that's everybody. Absolutely everybody. So we need to make sure that we're embracing all the cultures, all the people, all the perspectives that we possibly can. So again, opening ourselves up, feel uncomfortable, embrace that discomfort, and go forward. I do a small warning out here, because when we first talked about this in our committee, we were talking about having this event. As a person of color, I've had to attend a lot of these things, and I absolutely hate them. And at the point I stopped going into things, because ultimately, when you're in a room in the state of Washington, you might be the only person of color in there, and people are very scared to say something to you. When they do say something, it's either a little too comfortable, and I feel a little odd. So if this is not done right, you can marginalize a person of color even further. So things like that. And I'm not, I hate it. I did it last week. We were talking about like, even to a Native person saying something like something like that can be triggering. It's not. I understand what everybody's talking about, but just understand the different perspectives that every single person here has to talk. It's very important that we understand that going forward. And again, opening yourselves up to say that, yes, these things are real, and recognizing racism. It's a very important thing while we're talking about this. Diane Narsaki said this in our last meeting. It's something that we have to talk about. Let's put it in big blinking lights up here to say this is a real issue, not just in the state of Washington, but in the country that we live in, and that we have to embrace that as well. And all forms of racism have to be talked about here. So whether it's like a personal piece, institutional racism, unintentional racism, all these things, they're real. Just because somebody said that doesn't mean they're absolutely wrong, and you have to walk out of the room and say, well, shit, I just did that. And then feel uncomfortable where you're wrong. That's not where we're at. Please embrace that. Have this conversation while we're going forward. It's very important. And I just locked my phone, and I'm talking point. But yes, we do have to talk about these things. And as that person of color, I'm going to say it right now. The ties to white fragility and privilege have to be addressed. Let me look around. Everybody here, I know you're here for very good reasons. Everybody's here because they care about the community that they serve. That's an amazing thing. But these things do have to be talked about, because it is at the root of what we're dealing with right So again, I want to point that out and bring it out into the open for you so you don't have to do it later. So let me be the uncomfortable part right now. So go ahead and lay it out on the table and know that we can have real conversations now. Again, we are people who change things. Again, going back to that moxie thing, we are not where we're at because we're quiet about things. We're at where we're at because we wanted to change something, and we do change things for our community. And I encourage everybody here to embrace that and then change things for the better for our community.
Thank you so much. That takes incredible courage to smile standing next to the guy that contributed to the baby jail conversation. That is amazing. So you're going to inspire us to kind of lean into Thank you, Aaron. Are there anybody else is there anybody else from the last meeting that wants to share any thoughts? Or? How would you follow Aaron's comments?
He was like prodding me with his and Aaron saw us doing this. The conversation we had in the phone,
we want to acknowledge that everybody's coming from a different place. And that in acknowledging that it's going to be a true challenge to figure out how do we get to this place of health equity. But we hope that as we move forward as a group, not only are we urging and pushing ourselves and not looking at people like Aaron and me and now Maria's joined the group and Hallie to be the voices of reason, if you will, but that each and every one of us are continuing to make that journey and to make sure that we do achieve it. But the really important thing is being able to understand and acknowledge where each and every one of us as individuals are starting from and not make assumptions about where.
Thank you for that. Absolutely.
And this is to be hard work.
It is new for all of us, I think. Many of us. So I do want to just say, as Phil and I worked with Laura and the team and others of you to help shape the discussions today, it was really important for us to base the work in data, scope the effort, and then to figure out an action path forward. We sense there's still the need to frame the business case for investing and applying this equity lens at the organizational level. And as we looked across HILN organizations and partners, we noted there are many who are making this investment. Businesses, nonprofit, alike. So we asked several of you to participate today. We're going to ask Doug, our facilitator, so Doug Bose, if you'll come up, and Corey Sabaro, Diane Oakes, David Wertheimer, Anthony Chang is going to join us, and Drew Martin virtually. We have Drew. We can't get Drew from IHI, so we still don't have him on it. Anyways, they're going to talk about investing in equity and why it's really important to them and their organizations.
Hello. I'm excited to be here to talk about this because I think it's the next season. We've been talking about reinvestment for a long time here in the state, probably as long as I've been here. And you know, it's something that all the ACHs are talking about and trying to figure out kind of what our next steps are. You guys have been so kind to give me a bunch of things to say and notes here, so I will go through some of that. But we have the definition up there, and said we should talk about this several times. So again, our definition is health equity exists when all people have the opportunity to attain their full health potential and no one is disadvantaged. One of the things that we United know when we're talking about the business case is that part of the issue is that the funding streams are so different. So most of the health equity pieces are funded through grants or public organizations, whereas Medicaid is funded primarily through fee-for-service, and we're now moving heavily into value-based contracting. But they're very two different kinds of funding streams in two very different places. So how you pull that together is difficult, and the only way that we're seeing to do that is through a public and private partnership or partnership agencies, partnership with both public and private funding. So to that end, we've got a fund at United that we're looking to invest with, and it's probably close to $1 billion. We've funded various things throughout the country over the course of the last couple of years to about maybe $55 million for a variety of kinds of projects. And most of that has come directly from United. So what we're really looking to do over the next year and a half to 2 years is identify financial institutions and partners nationally and regionally that can partner with us around how we invest in the community. And one of the key pieces of this is we need to be able to invest in a way that doesn't make the system worse, more complicated, it doesn't duplicate, that is scalable and would continue to be able to grow on its own, and that additional investment to take things forward. So some of the things we've done is community center with different aspects in Arizona. We've done some housing in Arizona. We're working on housing in Los Angeles. We've done some things around transportation in different states. But I think ultimately the way we'll come to fruition on this is to work with the community, because every community is different. Every community has different needs. I mean, as I've gone around the state, I've heard a variety of different things. I've heard people say, I have a tract of land. All I need is for you to build a building, and we can make something happen there. Well, I'm not so sure we're going to be building a building, but I think we can do a public-private partnership to do something along those lines. Telemedicine, there's a lot that needs to happen with our provider community as we're integrating around addressing the rural needs. So telemedicine or a mobile unit or other kinds of things is something that is very doable, but needs a little bit of a push to happen within the community. And there's probably 50 or 100 other kinds of ideas about things that we can do. We're doing around the country what we call hot spotting, looking for places where things are really off the charts in terms of what are things looking like medically, and those tend to be places where there is inequity. So finding ways in those hot spotting areas to address what we need to address with the community, though, not United coming in and saying, we hotspotted this is what you guys need to do. That's not going to work for us, and it's not going to work for you. So I'm excited about being this group and getting that kind of feedback, and I think together we could find a way to move the ball forward. So with that, I'm going to pass down and ask everyone to introduce themselves, and then I think we'll get into some of the panel questions.
Good morning. Again, Anthony Chang, president of the Empire Health Foundation in Spokane.
Hi, Diane Oakes, president CEO of our Cora Foundation, statewide foundation.
David Wertheimer, director of community and civic engagement at the Bill and Melinda Gates Foundation.
Good morning. I'm Corey Sparborough with Group Health Foundation, the acting CEO. And Doug, we actually have 2 microphones.
So I could just fire questions at you left and right? So as you're speaking. So the first question is, what's your approach, including any data or evidence or promising practices behind investments that you are doing or looking for?
Wow, how much time do we have? So 2 years ago, we have over a dozen initiatives at Empire Health Foundation, everything stretching from reducing out-of-school suspensions to reducing the rate of uninsured in the community to reducing childhood obesity, you name it, we're doing social determinants and healthcare. And about 2 years ago, we made sure that every initiative had not only the primary metrics, such as we want to reduce the number of kids in foster care by 50% in 5 years, or we want to reduce out-of-school suspensions by 50% in 3 years. We actually added an equity goal to every single initiative. So, and I think without identifying where the disparity or disproportionality might be, it's really hard not to move that needle. And there have been some promising successes. So, for example, we partnered with Spokane Public Schools, and it's the second largest district in the state. You know, all of Spokane is maybe 11% diverse and 89% white, but you can see the demographic wave coming because Spokane Public Schools is about 38 or 39% diverse. Okay, so you can see the wave coming. And at Rogers, its largest, lowest income, most diverse high school, the out-of-school suspension rate was crazy. It was really, really high. And the disparity for African Americans was about 2 or 3x higher than the per capita number of kids in the school. And in 3 years, our goal is 50%. They reduced the out-of-school suspension rate by over 60%. So that was success. More importantly, the disparity for African Americans was virtually eliminated. Now, what's really cool about that is they then scaled up. So that was our initial investment. They then scaled it up district-wide, and they reduced suspensions about 30%, and they reduced juvenile arrests by 80% district-wide. Okay? And using the same ACEs, trauma-informed, restorative justice strategies that they had used at Rogers. But this work is a healing journey, which is, I have this wonderful Native American program director, and that's how she labels the work. And, you know, just as we had eliminated that disparity, the district looked at the data, and they were suspending special ed students 3x the rate, and that had gone up dramatically. And so now they're bringing in national experts and trying to train the staff that, you know, well, if you're on the spectrum, you're acting out in the classroom, maybe it's not, you know, disrespecting you, it's that they're coming and they have special needs. So it's a little bit like whack-a-mole, right? You know, you work on a disparity, you reduce it, eliminate it, and then another one can pop up. I would say that in our limited experience in the last 2 years, without actually identifying a disparity with the data and putting a hard target on it, it's hard to have investment dollars flow to it. And so, for example, we launched an initiative to reduce the foster care rate in Eastern Washington, and Native Americans are in the system 3 to 4x than they should be. We've reserved 25% of the slots in that initiative for Native American families. And again, we wouldn't have done that if we didn't have the equity goal. And so, but ask us in 2 or 3 more years how we're doing on all of those equity goals. But so far, the results are promising.
Hi, I wanted to share a little bit about the transformation that our foundation is going through around this topic of equity. Our relatively new name is ARCORA. It blends the 2 words ARC and oral. Drop the L at the end, make it ARCORA. And our mission is bending the arc of oral health toward equity. So if you picture an arc, the idea is that it's an arc towards the future. We work to change the trajectory so that over the long term, oral health care is delivered more equitably. Using this term equity and really having a focus on equity is pretty new to us. We're a nonprofit foundation, so we've always historically focused on underserved communities, done a lot of work with the Medicaid program and low-income populations, and seen lots of great improvements, kind of broad-based population-wise. For example, ABCD, investing in community health centers, investing in pediatricians and home visitors and Head Start teachers to address oral health with kids, really has done a lot to reduce untreated tooth decay among low-income kids in our state. We're one of the leaders in the country through a lot of work of folks in this room. But what I think we have been missing the opportunity on is really looking at subpopulations and looking at more focused populations. We previously had a kind of consideration around our investments around reaching large numbers of people. We thought, systems change means you need to reach large numbers of people. And we got to the point with children's oral health care where we started seeing the progress plateauing. But yet we knew there were kids not being served. We were at like 52%, 53% of low-income children accessing dental care. For medical, it's higher, so there's still a gap there. We're not at parity. So where are the kids that we're not reaching? Where are those families that we're not reaching? And so we started kind of attuning to that a little bit more than we had in the past. We also, fortunately, started really developing strong relationships with tribes and organizations serving Native people in our state. We're fortunate to have a board member come on our board, Joe Finkbonner, who's the head of the Northwest Portland Area Indian Health Board, that started kind of elevating our awareness more so around the impact of oral disease within tribes. We started getting to know great tribal leaders in our community, and that opened up our eyes to not only significant disparities, or really kind of focusing on the disparities that we'd known were there before, but just didn't really put the attention on that it deserved, but also the leadership and the innovation and the drive of tribal communities around the issue of oral health. And so we started doing things like doing a better job of looking at racial and ethnic disparities. So as we started to getting to know the tribes better, and there's a big thing going on in oral health with tribes right now called the dental health aid therapist, I think I talked about a little bit last meeting. It really is an example of a beacon that I think can impact the entire system of oral health care delivery. And I started shifting my recognition of innovations that come from the community. I think I used to think of it as, well, a little bit of added value, like that's an extra, like that's a, isn't it great that we can invest in community health workers as well as doing this other work? Now I've transformed to seeing, that is the core. That is where the solutions are that come from the community. The last meeting I was at, I just come back from Arizona or Alaska, and saw the dental health aid therapist training program up there, and was personally transformed by meeting the students that are going up there, spending 2 years away from their families, or some of them bringing their infants with them to learn a new skill in remote areas in Alaska. In my privilege, I didn't even want to fly in the little airplane to get there because I was too nervous. They're dedicating 2 years of their lives to come back and serve their community. And what I saw in their ability to work with patients from their community, I've never seen before in traditional aspects of the dental delivery system. And I think that really helped me to see how our institutions, many of them, whether it's healthcare, academia, philanthropy, have a history of valuing length of training, length of formal education over lifetimes of experience within communities, which is who we are in service of working towards. So that was transformational for me. So I think part of this work for me now, and the work at our foundation, is putting ourselves in the right places so that we can learn and then figuring out the right action. Data is really important. I was very excited with our partners at the Department of Health. The last SMILE survey we did together, we were able to co-invest in breaking out the Asian population so we could see disease rates for Pacific Islanders, and lo and behold, have the highest disease rates in the state with the groups that we have data for now. 26% of Pacific Islander kids have untreated tooth decay right now in our state, which makes it hard for them to learn and prosper and everything. So we've had a lot of learnings. I think that the business case, the impact for our work is that we would not meet our mission if we were not focusing on the even smaller populations than we've ever looked at before, where we're really seeing solutions come that can benefit the whole system. Stop there.
Could I throw a question at you?
Sure.
So RFP just came out, and we're looking at huge dental change potentially for the system. How does what you're doing, how might that impact that system? Or have you thought about that, or is that something you can talk about?
Yeah, so there is a lot of change going on in the Medicaid dental program right now as it's transitioning to managed care, which is a huge change, I think, for providers. It's a huge change for patients. It's a huge change for the system. And I just think it's a critical time for us all to be recognizing that's a vulnerable time. You know, there's likely to be some more confusion. There's likely to be providers that are trying to figure out how to operate in this new system. And so I think it's a lot more listening, a lot more staying tuned to what the specific needs are of different patient populations so that we make sure that in this transition, it moves forward our state and doesn't leave more people behind.
Thank you. So it's a pleasure to be here. And I want to start by echoing some of what Aaron said to us at the outset of the meeting and just reference the elephant that's in the room here in terms of this panel. And the philanthropic sector and how much work we have to do as a sector with, I'm making assumptions here, 75% of this panel being white. Well, and I will notice, Anthony, that your name's not even on the slide. So this is work that our sector has to do, and I know that the search that Corey and the Group Health Foundation just completed had this issue at the core of its search. But we are very much at the beginning of a journey on this, and it's reflected in the complexion of this panel. And so the Bill and Melinda Gates Foundation, where I work, has equity at the core of everything we do. All lives have equal value. Everyone has the opportunity to live a healthy and productive life, et cetera, et cetera. And translating that into what it means to actually do that work has been a challenging process here in the United States and here in the Pacific Northwest. The Pacific Northwest team, which I used to be part of, is 4 years into a journey on what it means to do equity grant making. And that journey was 2 years of excruciating pain and conversation for the team. And that team today not only looks very different than it did 4 years ago in terms of the composition of the team, but we now have equity principles in our grant making so that every single grant that we make has attached to it specific questions, specific outcome measures, specific disaggregated data components that relate to the equity issues that the team has prioritized and that are at the center of our grant making. So it's an important issue to us, but I also want to challenge a bit the issue or the silos we create here by talking about things like social determinants of health. So probably 5 or 6 years ago, I don't remember how long it was, Bob will remember how long it was, the Gates Foundation submitted its first ever policy paper on a health issue in the United States. Because our focus here in the United States was on education. That's our big bet in terms of equity, in terms of solutions in this country, because education ties more clearly in the United States to life success outcomes in terms of income, in terms of relationship stability, in terms of success of kids, et cetera. So our bet is on education, but it's an equity bet. And the paper that we submitted to the state as the state was applying for its 1115 waiver was a paper that basically said the social determinants of health and the social determinants of educational attainment are exactly the same thing. And I think it also applies to the social determinants of economic success. And we silo our conversations when we talk about the social determinants of health, or the social determinants of educational success, or the social determinants of economic success. I think we need to move away from that as we think about how we're working in a more integrated, holistic fashion to think about the social determinants of well-being. What are they? They're the same as the social determinants of health, educational success, economic success, but they're de-siloed when you talk about the well-being holistically of the individual. And this also relates to a fascinating conversation. One of the luxuries of working in the philanthropic sector is you get to go talk to really interesting people. And a couple of weeks ago, I was in Boston. I was at MIT, where I couldn't even find the building where the meeting was because the buildings are numbered, and they're numbered by an algorithm that you have to figure out if you're going to find the building. So I said I could never get into MIT when I was late to the meeting and finally found the building. But there's a really fascinating professor of urban studies at MIT. His name is Cesar McDowell. And we were talking about this issue of equity in investment. And I mentioned human-centered design as one of the principles that we're using at the Gates Foundation. And Professor McDowell said, and you should Google him because he's got some great talks on the web. He said, "I'm not a fan of human-centered design." And I said, "Wow." I said, "Why not?" He said, "Because too often when we do human-centered design, we start in the middle." He said, "And you will always fail if you start at the middle. You have to start at the margins. You have to plan from the margins. You have to think from the margins, or you will always fall short of equity-related goals." And the more I thought about that, the more I thought, wow, that is heavy. I have to really think about that. So what we're doing at the Gates Foundation now, and what my team, Community Civic Engagement, is really focused on right now is how do we think more holistically from the margins? And I want to pull us back to a health metaphor. I think that too many of us in the philanthropic sector, too many of us in the community, too many of us in all walks of life are focused too much on the symptoms and not enough on the diseases. The symptoms that we're all struggling with on a daily basis are things like homelessness, which was my work for 10 years at Gates Foundation, or educational inequities, or health inequities, which we all know abound across our state. Those are the symptoms. They're not the disease. And yes, the first job of the physician is to alleviate the suffering of the symptoms, but if you don't treat the underlying disease, the patient dies. And to me, there are three, at least, underlying diseases that we have to tackle, and our region has all of them in Trump. I have them all in Trump. Bridge reference, not a political reference. I have them all in Trump. And they are structural racism, gender inequity, and income inequality. Those are, to me, the diseases. And too many of our initiatives, too many of our conversations are focused on symptoms and not the disease. And now to mix my metaphors horribly, and then I'll shut up. Think about coal mines and think about canaries. John Nathan Haldane was the guy back in the early 20th century who developed the concept of sentinel species. And he was responsible for figuring out canaries as a sentinel species were much more sensitive to toxic gases in coal mines than humans. And between 1911, when he came up with this, and 1984, when a mechanical gas sensor was devised that could be worn on the belt of a miner, canaries and coal miners were inseparable. And if your canary in your little cage with you in the mine passed out, you knew to get the hell out of the mine because the gases that were affecting the canary first, and we're going to get you next. So we've been too busy, I think, trying to resuscitate canaries that are dying all around us and not recognizing that we're not dealing with the toxic gases in the mine that will kill us all. And again, those toxic gases that affect all of us: structural racism, gender inequity, income inequality. And the social determinants of health, which are at the core of the social determinants of well-being, which I think we need to reframe our language so that we break out of the silo of the health system. And I know many of the groups around the state are focusing on social determinants of health, which is fantastic. But I think the community will see themselves even more in the work if we talk about the social determinants of well-being. Where we have to go. We have to stop trying to resuscitate canaries, and we've got to deal with the gases in the mine.
Going last has its perils here, but we're also the newest organization in the state, so hopefully that'll account for something. I want to appreciate your comments in cracking the conversation open and echo what David said as well. So thanks, Aaron. I want to mention something. A couple things came up in the introduction, and then I'll talk a bit about Group Health Foundation and where we are in our work in the equity space and our equity journey. One, we talked originally, or at some point, that the session this morning was called the business case for equity, and I was going to point out that I think we want to ensure that we are also talking about the moral and human case for equity, which Bill pointed out for us at the introduction. I just want to raise that as well. And then the other piece in talking about the session, there was a focus on data, and I also just want to say what many of us know, that a lot of times data and systems have not served communities who are suffering from health inequity well. So as we think about how we intend to use data or go to data to support this work, just acknowledging that those systems have not served us well in many regards, and thinking about how we need to remake those systems, start fresh. And particularly a lot of organizations now are talking about disaggregation of data. I think that's a good start. I think that's only a start. I think there a lot more work needs to be done on that to ensure that that data is serving us well as we make progress in equity and health in our communities. So a bit about Group Health Foundation. We were launched in February of 2017. And just for those of you who have been very involved and understand some of Group Health's history, there was a long-standing foundation that existed largely to support efforts at Group Health and some community work as well. That foundation still exists and is part of the new merged organization. So we have a long-standing 501c3 foundation that did not stay with Kaiser, that came with us, and then we have the new foundation that was funded by the proceeds of Kaiser's acquisition of Group Health Cooperative under one umbrella called Group Health Foundation. The new foundation is a 501c4, which gives us considerably more latitude in the public policy and advocacy space than we would otherwise have. So that is an exciting component of the organization. And we do also have a statewide focus. So something I like to clarify, Group Health was in various places around the state, but not statewide. And the foundation intends to serve communities all throughout the state. Just for context, we are one of about 200, depending on whose article you read, 250 health legacy foundations that exist around the country that have been born in the last 30 to 35 years as the transitions in health and more for-profits get involved in that space that was formerly held by a lot of nonprofits. Our transaction was a little bit different because both Kaiser and Group Health were nonprofits, so I won't go down that rabbit hole. But our transaction was a little bit different. But safe to say, we look and smell a lot like the conversion foundations that many of you are familiar with. The primary difference was in establishing this foundation, there was not oversight from the Attorney General because it was not a conversion; it would involve just nonprofits. On a per capita basis, we're about this, probably the second, numbers change frequently, the second largest health-focused foundation in the country, with an anticipated grant making of about $65 million a year. So we hope to be significant partners with many of you in advancing health equity. We're just getting started. With all of that said, the organization, like I mentioned, launched in February of 2017. The long-term board of directors started in April of 2017. So Group Health Cooperative had a subcommittee of their member-elected board of directors. They were tasked with being ready to accept resources and staff an organization if the transaction happened, and also to select the long-term board of directors. There was a mandate from the trustees to have this be an organization of the community. So on our current board, we have 16 board members. There are only 4 of those board members that have prior connections to Group Health Cooperative. So there were 4 board members. They also have the shortest term limits of all 16 members. So the organization is led from a board perspective by 16 people from around the state. It's quite a diverse group. It's more than 60% people of color. Half of the board is women, and that is also true in all of our leadership positions on the board as well, in terms of diversity, which is, I think, a critical ingredient. Just to echo David's point, that is a prerequisite, I think, in many cases for organizations that are serious about doing this work, and certainly true for us in terms of our board and staff development. So how did our focus on equity evolve? It evolved fairly quickly. When the organization was launched, Group Health Cooperative set forth a series of principles that they hoped would be part of this new foundation. Those evolved into what we now articulate as our core values. When the new board came together in April and through subsequent meetings and examined those values and started to talk about how we were going to live those values and which were more critical in the event of desire to prioritize them, it was very clear that the organization was going to have equity as its leading value. So our mission is around advancing health equity and community aspirations for a healthy future. So we spent the last year having additional conversations about what that means for us as we begin to do this work. We're in very much a learning phase. We've done some limited grant making, but we're in learning and listening mode. So we have spent quite a bit of time as an organization further defining for us what it will mean to lead with equity in all that we do. And by that I mean with our vendor selection, with our internal work as a staff, and then of course with our program work in the community. And I'll just highlight, we actually put a handout in the packet which has our equity agreements in greater detail, but I'll just pull a few of these things out. This will sound familiar to a lot of the work your organizations are doing. We start, of course, as Aaron mentioned, with recognizing the foundational role that racism plays in perpetuating health inequities. So that's a key belief that the organization holds. The next is relying on the wisdom of communities as we work to advance health and health equity. The third is an acknowledgement that our investments will not be equal, but they in fact will be based on where we are seeing inequities, where communities are seeing inequities. And then lastly, just acknowledging that this is a long and bumpy and complicated and uncomfortable journey, and that's part of what we remind ourselves at every board meeting when we get into this work and have these conversations, that's to be expected. And if it's not at least a little bit uncomfortable, we're probably not pushing hard enough. So those are a few of the highlights. We have developed what we call our evolving equity agreements. It's very intentional language to acknowledge that we're trying, we're moving forward. We are likely to make some mistakes. Hopefully they will be small, but inevitably there will be some big ones, and we will continue to revisit that. But it's our articulation of our collective shared understanding of how we want to show up in relation to our work around health equity. It's a way of holding ourselves accountable, and by sharing it, a way of inviting others to hold us accountable too. So that's part of our work. So with that, we have, I just want to mention one other thing. I'm an acting CEO. I was hired to help launch the organization. Our new CEO, Nicole Maher, many of you may know, she's down in Oregon running a Northwest Health Foundation. Very similar organization to Group Health, a little bit smaller, but very similar values. She starts October 1st and will be really leading our long-term strategy development efforts. So we're in learning and listening mode and building relationships, and then she will be leading that effort, which will be quite fun for all of us to be involved with. Thanks.
Thank you. Just an interesting stat that I'd like to throw out there. You know, we've looked across the state and federal level of public money available for Medicare, Medicaid, food assistance, housing assistance, and job training across the entire country over the course of this past year. There's proposed $2.5 trillion in budget cuts. I mean, so this becomes much more important as to how do we bring the right people and the right things to the table to make things happen. I mean, that's a huge cut. It's going to put so much more pressure on the system. I love the well-being equity piece that you brought up, David. And the final question really is, what would you ask of this group? And you know, how can this group help for all of us that have some opportunity to contribute to the system? To me, there's a few things. One is, you know, help bring things that give us really good cross-sectional data. You know, things that have scope and are scalable, that could be used in one place but used in other places, not a kind of a one-timer kind of a thing. And then the last piece is, if we can determine what we want to do as a group or in pockets, that we really provide some collective advocacy to get those things done. So those would be the things that I'd be looking for from the group. But pass it along.
Well, we've been struggling with this in the Equity Accelerator Committee because we made a commitment that we didn't want to just look back for 2 years and say, well, we met a lot of times, but what actually happened, right? And so I think what I would ask of each of you, you're all leaders and some role in your organizations, otherwise you wouldn't be in this room, is to take what you've heard here today and I think synthesize the business case, right? Usually what that means is there's a monetary reason to do it, okay? And frankly, when you talk about equity, there's market-driven decisions that your organization can make, and then there's market failure, okay? So you'll have to think about and probably categorize what can my organization do to address inequities that we can actually sustain, and it will in fact potentially make us net positive, win-win, right? Right. But I always said to my founding board chair, who's the CEO of a for-profit manufacturing company, and at first he wasn't sure why we were doing some of the things we were doing, because he said we should be applying business principles. And I said, well, if you can think of a way to reduce child abuse and make money at the same time, I will start that business. And he thought about it and he said, I can't think of a way to do it. I said, that's market failure. So we as a society, we as a community have to tackle that, okay? And so we as organizations have resources. We're all here because we actually have some responsibility over resources, okay, and teams. And so we can make a decision and say, look, over here there's an inequity, and we can make an investment, not because there's a business case, but because we as an organization, it demonstrates our values to address a market failure. Now, that doesn't mean that there isn't business case, right? So you think about, I think, John, it was you 2 years ago, and you stood up here and said, we will be majority minority in Washington State in 10 years or something like that. And 2 years ago, you said that we crossed the line that the entering kindergarten class in Washington State was majority minority for the first time. Because I wrote it down in my notebook, okay? And I just looked it up. 36% of Medicaid patients are diverse, and it's, of course, the fastest growing percentage. So whether you're a payer, a provider, behavioral healthcare, whether you're an agency, okay, if you intersect just even with the Medicaid population, and it's growing, okay, and I'll just give you a quick kind of business case. So we're talking to one of our tribes in our region, and they don't want to do VBP. Why? Because the whole premise of VBP is you have a distribution curve of patients so that the high end is subsidizing the low end, right? Essentially, okay? And if you have, instead of this, you have this, you will never get ahead on VBP. You'll just lose money, okay? So apply that to the state, to your own patients, to your own clients, to your own organizations. That high need population is going to grow. And so if you don't figure out how to address the sustainability financially, or even net ahead financially, you're going to go out of business in some form or fashion, or funding cuts will kill you, or whatever the case might be. So I think that, you know, listening to the conversation here is a really important distinction. I would ask each of you to think about those two categories and what you're doing in each of those categories. And I guarantee if you look on the, especially the business side, you'll find some hotspot, right? Who there's, it's the classic, people know the Pareto rule, right? 80-20, 20% of your patients or your clients are 80% of your cost. And there's a, actually it was a executive from United National that told me they have a, you have a 550, 5% of your patients are like 50% of your cost, or 15%. I forget what he said. It was like a 1550 or something like that. So, you know, my ask to you is like, go look at it. Go look at that and come up with somewhere where there is that win-win just to get started. And there's going to be some places where it just won't pencil. And you got to make the hard decision to be values driven and go for it.
I would say thank you to the Equity Accelerator Committee and others that I think are looking into how this group can continue this conversation, deepen this conversation, learn together, talk about institutionalized racism and social determinants of well-being in a deeper way, in a more authentic way, because what I'm looking for is really a learning community. And I think that we can be multipliers of each other's efforts. And what an opportunity to play off of what Aaron shared this morning. I mean, this room is filled with very influential people, and it's a privilege, you know, to be in this position. And I feel like any learning that I can do that boosts my development, so it maximizes my ability to impact, it's just, I'm so thankful for it, you know, being in this position, and we're all in that situation here. So what I'm really looking for is, partners, learning community, and having these conversations on a regular basis and getting to action. The other value is urgency and persistence. And when I think of urgency, I think of the missed opportunities that I felt our foundation has had over the years, and any regret I have is not jumping on something earlier. And sometimes it just takes a leap of faith and not having everything kind of figured out exactly what the logic model is. And, but having a true partner in the community that you trust that says, yes, we think this is right for our community, and leaping in. So urgency and persistence. Because this is hard work. It's a journey, it takes a long period of time. And if we ever start feeling like, I don't want to go there again, I don't want to have that conversation again, think about the families. I talked to our staff about how hard it is for a parent to come home after working 2 jobs and find out their child is in pain from a toothache, and they have to find a dental provider the next day to take them to them, and they're exhausted and, dealing with so many life issues. That level of persistence is what we need to put on ourselves, at least, if not more, because of the positions that we're in. I had one more thing that I was going to say and I lost it. But yeah, thankful for this opportunity and for all of you.
So I have one sort of general thought and one very specific recommendation. The general thought, and I want to salute all of you who are involved with ACHs in various parts of the state and the work you're doing to ensure that the non-primary care systems are at your tables and talking about social determinants of well-being together. And on that front, having worked in government, having worked in the philanthropic sector, having worked in the nonprofit sector, I know that the blending of funding is really hard to do because everybody wants to know exactly what their dollars are going towards and what outcomes are associated with their specific investments that follow legislative mandates, if it's public funding, or priorities for foundations or whatever. And so I think more about the importance of talking with our partners together about braiding funding, which is different from blending funding. When you braid funding, you can follow your specific strand wherever it needs to be tracked for accountability or for priorities or whatever. But when you effectively braid together, you create this absolutely gorgeous tapestry, right? And that's what I think we need to do in our ACHs and in our communities, is to create these tapestries, which are the composite combination of everything we want to create in our communities. But you can see your own thread of your funding stream of your work if you need to in that effort. So braiding of funding rather than blending of funding, and really working to continue to pull those non-primary care folks into your conversations, to your tables, to be part of the conversation about the social determinants of well-being. That's the general thing. The specific thing that I want to highlight, which is becoming increasingly important to all of us and a focus more and more of the work that I'm doing, is Census 2020. Tens of billions of dollars of federal aid are dependent on the results of the census, as well as the distribution of members of the House of Representatives across the United States. It's an incredibly important 10-year process. And if you look at the census data historically over the last 3 or 4 censuses, you actually see in Census 2010, the Obama era census that Gary Locke, in fact, led as head of the Department of Commerce when he was in the Obama administration. That census made some significant corrections to historic undercounts of very important marginalized communities across the United States. We are at risk of losing all of that progress and more in a census process that is talking about including questions about citizenship, that's talking about being entirely an online tool, and that is being promulgated in a federal context right now that is one of fear and anticipation and questions of competence, et cetera, et cetera, et cetera. So in all of your circles of influence, from the agencies that you're part of, to your partners, to the communities that you're working in, it's going to think over the next year and a half, because this is going to be on top of us before we know it. It's going to be incredibly important to figure out how Washington State creates the most accurate possible census numbers for our state as we can. And this is something that can be shared at the intake desk at a health clinic in terms of here's information about the census, here's how to participate. At the board levels and all the boards that you sit on or that you staff, and the tentacles of community engagement that those board members represent. This is a critically important moment upon us, and my worst fear is that through the combination of malevolent intent and sheer incompetence, we're at risk of a disastrous census 2020. And each state, in California, the state legislature has already allocated $43 million of state funds to augment census counting activities statewide in California because it's that important to them. The equivalent amount in Washington State would probably be about $9 million. That money is not necessarily forthcoming from the legislature. It's got to be forthcoming from other sources. Some of us sitting here may be some of those sources, but it's really important.
I'll just say very quickly, thanks for having us. We are looking forward, now that we have some staff and are starting to hire more staff on the external program grant making side, to being more engaged with you in these and other partnerships. And the one request that I would make, philanthropy doesn't, people don't criticize philanthropy, at least not to our faces very often. And I won't make an invitation on behalf of all of my colleagues, but just on behalf of Group Health Foundation. As you see us unfolding in communities across the state, we would really welcome feedback, particularly critical feedback, as we embark on being a part of advancing health equity across the state. We'd really like your commentary when you see something that is amiss. So consider that an invitation. You can tell the incoming CEO that I made that invitation and promise, and I'm sure she will embrace it as well. So thanks.
So let's give these guys a round of applause.
Thank you.
And what a great transition segue, because I love the humility of what you all have offered. And I just want to take us into break. But some of the themes that I heard, and Bill, I'm going to ask you to join me, but I love this acknowledgement of discomfort, the awkwardness, that the urgency. I think that the learnings of wisdom of community, and that how all of us have to keep really being hyper-vigilant about all health and well-being is local to communities. I loved where you talked about solutions have to come from community. We know this. The shared learnings, the listening, getting out into the field, seeing. I loved your comments about the census and precision data. We talked about that last meeting, so just some of those themes. You'll always hear public-private partnership from me, because anybody that thinks government's doing this alone is just not so. And then I loved the theme of market and mission, margin and mission, that business principle, and just kind of really that values alignment. So those were some of my just wrap-up themes. But Bill?
So I was watching Sue take notes, and I was writing the same things down. So sometimes that's true. So one of the things that I picked up on early in the conversation, what I really liked, is that the social determinants of whatever it is, health or success or education, are really essentially the same kind of thing. So the social determinants of well-being actually is kind of an integrative idea, and I like that was brought out. I also going to play a little bit here on business, the business case, and Anthony talked about it may not be about return on investment, but it probably is about being sustainable. And that is actually a business way of thinking about it. If it's not sustainable, it goes away, and then no one benefits from that. So I thought that was a really interesting idea. And then I also liked the idea that we should be a learning community, and we were invited to that. And I think we learn better as a community in many ways. I know I do. I do better in a conversation than just on my own. So some of the things I picked up. So we're going to break. We have about 10 minutes, and then we'll come back here, and there's coffee and facilities and good people to talk to. So we'll see you in about 10 minutes. Fantastic. One time.
I'm sorry, Chase. This is Drew. I want to see if you want to test it one more time while we're on break. I can see when I talk, the microphone levels rise, but what you're saying is you guys can't hear me at all, right? Okay, I may have called the wrong number. Okay. All right, thank you. Oh, okay. Oh, okay, I got you. I got you. Sorry about that. Hey, I just wanted so when I'm actually talking, like my screen lights up and the microphone levels goes, but obviously you guys can't hear me. I've tried two different computers, so I'm just letting you know.
Something here.
Testing, testing, testing.
Hello?
I could looks like I should be heard.
Yeah, that's
in this building, and my screen is lighting up.
okay. Let me try one more. Yeah, no. I don't think it's on your end. I think it's this room. Okay. Can you try talking to the computer microphone again? Let's see if this works.
Testing, testing, testing. Yeah, nothing.
Nothing. It's straight, and it shows you. It literally shows the volumes when you talk. They pop up on the little thing. So let me try to turn the internal volume again. There's feedback, right?
Testing it or feedback?
Yeah. Okay, let me try one more thing. I think if maybe I can disable something. Disable my.
Testing. Hey. Testing. Okay.
Yeah.
Yeah. I tried. We tried.
I'm gonna grab one more option here. I think. Let's see. Got a lot of options here. None of them seem to work, but
Can you see me on the webcam?
Yeah, oh yeah, let me try this one.
Do your thing. All right, testing. That's bad.
We're getting close. Wait, let me move back. Okay, so I'm picking you up the audio on the cell phone.
Yeah. My cell phone's been mute the whole time, so.
Oh, yeah, I'm
sorry. Just tell Laura. We'll take it over next time. All right. Testing.
Yeah. Okay, Joe. Thank you. Yeah.
Oh, okay. All right, no worries. All right. Okay, bye.
Thank you.
All right. Shit, I got some open. So I invite you to find your place again. We had a long 10 minutes, and it's good to hear the conversation, but we're going to get started with the last hour of our time together. So we have just about an hour left today, and we have a really interesting conversation to have around communities leading the way. We have a panel of 4 people. Kennedy's going to be the kind of the moderator of the group, and we have Maria and Haley and Hani with us, and I'm going to let Kennedy lead
off, and we'll get started here. So Kennedy, thank you.
Thank you so much. We'll just wait a minute while we get settled. No worries. Thank you for the opportunity to allow me to have this conversation and facilitate this conversation with Healthier Here, representatives from Healthier Here, which is King County's accountable community of health. They are part of the Community Voice Council, or what they call Community and Consumer Voice Committee at Healthier Here. I'm reflecting on what I've heard today, and we are talking about our role as stewards of resources and leaders to make change on a system-wide level. I think from my perspective as someone who works for the state of Washington in the realm of policy is that we often have requirements from our authorizing environment to engage the public. So what we want to do is engage the public in a meaningful way and not have that be a box that we just check. I think from my perspective, I think Washington does a very good job of engaging the public insofar that we listen and we hear and we say, we hear you. I think now is the opportunity to go from we hear you to we've heard you, and here is how we are adjusting, changing, advancing our policies because of what we heard. So what I really appreciate about this opportunity today is having the conversation about what we're doing up here, and also inviting the people who we are wanting to and trying to listen to, and saying, how can we make that connection? And how can we start to adjust the way we think about the work that we do because of what we're hearing? With that, I want to ask the panelists to introduce themselves, and if you wouldn't mind letting us know how you got involved with the committee and any reflections on what you've heard already today.
My name is Hani Mohammed. I work at Community Health Plan of Washington, which is a non-for-profit health plan here in Washington State. I have been a part of the committee for at least, I think, a year and a half now. I've been going to these meetings. Before that, I was at Community Health Point Community Health Center, so that's kind of where my health equity work has started, and I've heard some really great things this morning. As you can see, I walked in a little late, so my apologies, but I'm excited to be here and I'm excited to share this experience with you.
Hi again, I'm Haley Pritchett. I'm the director of the public health program at Lake Washington Institute of Technology. Some of you may know my president. I guess she was a member here for a few years. And I am representing a community voice for the Community and Consumer Voices Committee for Healthier Here. I have been on this committee since fall of 2016, and I actually found out about it from being on another equity committee for Healthy King County Coalition, which I've been involved with for a few years longer than that. But as an academic, I find that I still need to get out in the industry and function and actually do things. So I'm always on various coalitions and committees and associations, and I got started. I have a lot of responses to some things that I've heard. Again, academic, sorry. But I've kind of infiltrated it into some of my answers. So as we go through the questions, I'll just kind of add those in.
Again, I'm Maria Gingrey. I am the Director of Equity and Community Partnerships with Healthier Here, again, Seattle and King County's accountable community of health. It really is a privilege to be with you this morning and to share some thoughts and comments as well. I sit in a very unique position in that I have been involved with the Community and Consumer Voice Committee actually since its inception, as part of the planning, as part of our interim leadership council for our accountable community of health, and then as part of our governing board. So it's interesting for me, having approached this work from a perspective of being a member of community who was providing input, guidance, and feedback from a community and consumer perspective. Then also serving on the governing board. I held a seat on the governing board, so I had the opportunity to influence and shape some of our policy, our values, our guiding principles around equity, partnership, and authentic community engagement, to now joining the staff of Healthier Here in April to begin to actually operationalize the work that we're doing around equity and authentic community engagement. So today we're going to hear more from Hani and from Haley, because one of the most important things that we can do in reflection on some of what was said today is that, as Kennedy pointed out, it's very important for us to have our values. It's another thing to operationalize those values, and to engage in authentic community engagement means that we ask people what they need. Ask them what they need. I don't know if any of you had the opportunity to attend the Policy Link conference that occurred in Chicago of this year. Such a powerful conference, and if you can, I encourage you to take a look at their website and view any of the materials from that conference. That conference was focused on solidarity and policy making and decisions and planning and conversation. Because oftentimes what happens is when we are asking community to engage with us in a government perspective and an institutional perspective, we've already done a lot of the planning that occurred. So we're really not asking the community to provide input in shaping the decisions. We're asking community to check a box and rubber stamp what we're doing. Part of the reason that we often do that is because it's easier for us to do it. It fits within our normal institutional way of operating and way of being. But how's that working for us? It isn't. So instead, at Healthier Here, we've embedded authentic community engagement through all that we're doing through the Community and Consumer Voice Work Group by recognizing that people who are closest to the problems are closest to the solution. People who are closest to the problems are closest to the solution. So then what is our role and responsibility in terms of doing something about that? It's creating a space to ask those who are closest to the solutions what they need, to listen to what they say they need and honor that. And then get them what they need. And that means don't overpromise and think that you can say that you can do everything that community identifies they need. Recognize that we are all only one part of this larger system. However, in doing that, also recognize the power and the privilege that we hold in these seats, which is something I was just thrilled to hear in the earlier conversation, the references to power and recognizing the power. And so what that means is, even if I can't contribute to the solution, I can get community in front of the right people who can. I can get community to those tables. And most importantly, I can get those decision makers out to community tables. And then once we listen, once we ask, we listen, and we act, get out of the way, right? Let community do what community does best. Too often we approach this work from a what do you need, what do you need, what do you need, from this needy place. We're not recognizing the strengths, the power, the resilience that exists within our community. So when we ask, listen, get folks what they need, and get them out of the way. How do we operationalize that? One of the things that we're doing at Healthier Here is operationalizing those principles through our Community and Consumer Voice Work Group.
Thank you. Very well said. I'd like to ask a question of Haley. You mentioned that you have been on equity groups before, and you've been on this one since 2016. Can you reflect for us on your experience being on such councils, and what are your areas of hope and what are your areas of frustration in this type of work?
Sure. Forgot about the microphone. So I'm going to start with areas of hope and areas of frustration really quickly. When it comes to being on equity committees, equity innovators, equity accelerators, equity work groups, whatever, we often get bogged down by things like language. What does equity mean to us? What is a social determinant of health? What is a determinant of health? What's a determinant of equity? And we will discuss this ad nauseum and never actually get anything done. That's one thing I desperately want to see us get past. Another thing, and I'm sure some of you have heard this term, is fakequity. I see a lot of people who come into the realm and they want to say that they are expert at equity, and I'm sorry, but none of us are quite expert at equity. We're all different. As Teresita mentioned, you know, we all come from different backgrounds. We all have different levels of literacy. We all have different priorities and different things that we're seeing within our communities and in the people that we work with. And you can't come in and say, this is what I'm going to do, and then sit at a meeting and check a box. And it doesn't work that way, but that seems to be what happens. I was very pleased to see in the funders that were up here that there's definitely an awareness. And people, especially funders, are starting to kind of think with that moral lens. And I found that really uplifting and hopeful. But then again, I was actually, sorry guys, kind of hoping to see some more of that, that business reason. Why invest in equity from a business level? What do I go, if I want to go to Chase and ask them to invest in equity, how do I get them on board, right? We have funders here who are at the table who already are using that moral lens, or at least thinking along those lines and working towards that systematic change and organizational structural change, which is amazing to see and it's great. But what I'm not seeing is, okay, well now how do I take that language? If I don't go get my doctorate in health economics, which may end up happening sometime real soon, but you know, how do I take that language and bring in people who are not already into the conversation to actually make that change on a systematic level?
Thank you. Hani, I'd like to ask you, why is it important for you to contribute to this committee, and what action are you hoping to take through this committee work?
So I've been doing equity work for some time now, as I mentioned. And I think for me, it's really recognizing it and acknowledging the resilience and the strength of the community, and understanding that the strength is there and the will is there and the need is there, and allowing, really not allowing, but providing the resources and the space for the community to do this work. And a lot of what I've been doing personally in these settings and in these environments is asking people to change the way that we think about the community and how we some of the language that we're using. For example, we say that homeless person, this is an individual who's experiencing homelessness. And I think it's really important that we recognize and we acknowledge that words do indeed have power. And when we think about, like, saying low income, these aren't communities that are low income, they're economically disadvantaged, and are marginalized. So it's making sure that we're taking away the blame from the community and acknowledging and understanding that this is a systemic issue. Individuals in my community and the communities that I serve don't want to experience these systems and don't want to experience these levels of oppression. They're experiencing because of the system that we're all within, and that we all need to really change and make sure that we're doing it authentically. And I think, you know, just echoing again what's been already said, is I hear so many people doing this work. It's like equity, inclusion, like that's great, but what are you actually doing? And are you doing what you say you're doing? We're in these spaces and we're having these conversations, but I'm having a really hard time seeing this work becoming operationalized. And it's frustrating because as a woman of color, I could very easily say that I feel like the interpersonal labor is on me and on people that look like me, because it's, well, you know, you're in this position and you come from this community. What can you offer us? It's like, no, let's think about this differently, and let's not think about it in terms of what can the community do, or what can I do? What can the system or the organization do? But what can we do to help the community do this work? And I think that's what's really important here, is not expecting, you know, the community to really not expecting the community to do this work by themselves. I think, and I think that's really what it is that, again, that labor sometimes is put on us and can cause some frustration and some like, why, well, you know, what can I do, and why am I in this space, and is it valuable? Because I feel like sometimes I'm the spokesperson, and I'm not. Like, I have the lived experiences, but so do many others. So it's making sure that we're creating really that authentic space. And I think one of the principles that we have as the CCV is addressing health disparities, inequities, and social determinants of health with a particular focus on race. And we know that makes people, like, hearing the race word makes people feel very uncomfortable, especially within the healthcare field. But this is what's happening, and this is what's happening. I, as a woman of color, succumb to certain health disparities simply because of my race. And until we acknowledge that, it's going to be very difficult for us to do this work. Race is an issue. Racism is an issue within this country. And until we acknowledge it, until we can all acknowledge it, and they all acknowledge the privileges that we have, it's going to be very difficult moving forward with this work.
Thank you. I like the idea of moving from awareness to action. I think we all want to do that. We want to operationalize this work. What elements are missing in order for us to get there? I'll just open it up to anyone.
So that's a great question, and that's an open forum to be able to have a much deeper and richer conversation. And I'll begin and answer with kind of taking a look at, first and foremost, how you begin to operationalize this work. And then we can talk about what's missing. My particular background is I've actually been working to advance equity and social justice for the past 28 years of my career. I'll acknowledge I started when I was 2, so for those of you in the room, you'll know when I say that, but for those of you on the phone, just humor me with that. And it's very interesting because something that was said on the earlier panel from the funders is recognizing that this work around equity is not necessarily rocket science, and yet we approach it in a siloed fashion. So I've had the opportunity to work in the transportation system, the criminal justice system, education, public housing, and health, as well as doing some work around discrimination laws and policy making and enforcement. And what's been interesting for me is that what I see in the education system is the same thing as in the health system, is the same thing as all of these systems. So oftentimes we try to make things more difficult than they need to be. So instead, what we have done at Healthier Here is we have utilized a comprehensive approach that allows us to embed authentic community engagement and equity in everything that we're doing. So from a perspective of how do you do that, you'll see at your tables in the center, you have a packet that I'm not going to walk you through everything in that packet, but I just wanted to highlight that for you. And I'll also send this electronically so that it gets out to folks who are on the phone. And just to highlight for you that one of the things that Hani just referenced was the Community and Consumer Voice Committee's mission and purpose, right? So we actually have a charter. Our governing board has formally adopted the Community and Consumer Voice Work Group. And I have to thank our governing board for having the courage and being willing to lead in that way. So one of the first principles is that we have to address equity and authentic community engagement from all levels, beginning at the board level. We're fortunate at Healthier Here in that we have a 26-member multi-sector board, and we have a couple of our board members here with us today. We have Teresita, and we also have Sybil, who is here. And we are fortunate in that of those 26 seats, I believe 6 or 7 of them are actually designated. Oh, and I'll also reference Erin. Erin is not an official board member, but Erin represents one of our co-chairs, in that our board is co-chaired by Esther Lucero and also Betsy. Where's Betsy's name escaping me? Lieberman, thank you. Thank you. And as many of you may or may not know, again, for those on the phone, Esther Lucero is the executive director of the Seattle Indian Health Board, CEO of the Seattle Indian Health Board. Thank you, Erin. The reason that I mention that is that our leadership is reflective of our values and our commitment. And amongst our board, about 26 seats, 7 of those seats actually, are designated for community and our tribal nation representatives. So roughly 35% of our board composition is walking and reflecting in our values of equity and community engagement, and has done so not only by formally adopting the Community and Consumer Voice Committee, but also the second principle of something that is important to operationalizing this work is resourcing it. We have to recognize the power that we hold and the doors that we can open where and when we can. And one of the most important things that we can do institutionally is resource the work. What we resource gets done, what we measure gets done. So our governing board has allocated a portion of our budget to directly go out to community to allow community to do what community does best. In this particular fiscal year alone, we've allocated $350,000 that has gone directly out into community through the Community and Consumer Voice Committee. And that contract is actually being managed by one of our community partners, the Center for Multicultural Health. So it's one thing to resource it in your budget line item, and it's another thing to resource it and actually put the money in the hands of community to position community to do what they do best. One of the things that our Community and Consumer Voice Work Group has done is they've developed a community engagement plan, a copy of which is included within your materials. In that plan, again, it speaks to how we operationalize this work around equity and authentic community engagement from community's perspective. So going back to that, ask people what they want and need, listen, and act. So the action is developing a work plan that has been designed and guided and developed by our Community and Consumer Voice Work Group. Contained within that work plan is resourcing that goes directly out to community groups and organizations who have historically not necessarily been invested in a small grants program. So our Community and Consumer Voice Work Group has developed the small grants program, and a copy of those guidelines, again, are contained in your materials. I highlight those items as some of the things that we need to do if we're actually going to live our values around equity and authentic community engagement. And then from an operational perspective, how we actually embed that work. Healthier Here is doing a lot of work and is doing a lot of things well, and also acknowledges that we are going to be learning along the way. We expect to learn along the way. As you do this work around equity, it gets messy. It's much easier, as Hani pointed out, to argue about what's our definition of equity. Well, are we talking about equity or are we talking about diversity? Well, I don't know. I thought diversity was cultural competence. But then again, is that cultural humility? We could spend the next 10 years arguing about the definition as opposed to doing the work. And the problem with that is that people are dying. Our community cannot afford for us to play a semantics game. Community needs us to act. And I pause there as well because recognize that as we are sitting in this room, not just the folks sitting on this panel, every single person in this room is a community member. We are community members first. Think about healthcare. Think about outcomes that you want your family to experience. that you want to experience, that you want folks who are going to be coming behind you to experience? Do they have the luxury of waiting for us to argue over a definition to get the semantics right for the next 10 years? No. And that's often one of the things that's missing as we move to operationalize, is that we get in the comfortable place. It's comfortable for us to argue about semantics. It's comfortable for us to say, let's put together a timeline and a work plan, and then we'll do some project management associated with this work. Scratch all that, right? How's that working for us? It hasn't worked for us in the past. Therefore, I think it's pretty logical to assume it's not going to work going forward. So instead, flip the script. And the script flipping is this. People do not care what you are doing until they understand why you are doing it. How many times do we within our institutions and organizations stop and have that real hard question about why we're doing the work? Beyond the data, beyond the numbers, but the why. What brings you to this space? Why do you want to make things different? And how is that going to matter? And those are conversations that are uncomfortable because it's easier for us to, again, talk about the timeline and the work plan and the activities and the performance measures. That's easy for us to talk about. But until we get to the why and why it matters, we're never going to get to the place of really doing the hard work.
I have something to add. Absolutely. So also just to add on to kind of what's missing with Healthier Here, with those of us in this room and your organizations, I know a lot of the organizations here in this room are associated with ACHs and supporting ACHs. But the things that I'm seeing are missing are things that were actually already mentioned in the funding panel. So I know that Anthony brought up data, identifying the data so that you can actually put it to an equity goal, identifying an equity goal to look at in the first place so that you actually are gathering the correct data, right? So we're seriously lacking on data. That is one thing across the board. And I know that's something that DOH has been working on tirelessly with fundamentals for public health in the last year or two. But there are a couple other things in terms of looking at integrated models. We look at integrated models, and when we hear the word health, we think of healthcare. And integrated models, some of you have already mentioned this, like I said, in the funders, is education and housing and economics. These are not mutually exclusive concepts, right? So we need to be bringing in schools. We need to be bringing in people who work in housing. I know North Sound ACH was doing a lot of this just a few years ago. I went to a conference. They had an amazing connection with housing authorities in association with their Medicaid transformation goals, right? And then the other thing was, and Erin brought this up at the beginning, and I'm sure this is going to be like repeated over and over again, but looking around the room, but David echoed this, and Corey, you even mentioned this kind of in terms of your organizational structure. We need to be looking at all of our organizational structures, our staffing. We need to have more people of color, more women. We need to fight that gender inequality and inequity. And that income inequality. And if we don't do that, then we're not going to create the systematic change that we keep trying to say we're going to fight towards.
Just echoing that, investing in leadership within our communities. I think that's very, very important. And I think once we do that, we're able to really authentically do this work because the voices are authentic because they're coming from the community itself. So I just wanted to echo that. And I think another thing is also just really understanding the historical significance. Because I think that's really important and something that folks want to deny sometimes is understanding the historical significance of why these systems are put into place and who they're benefiting and who they're not benefiting. I think those are two things that are really, really important because that's missing from the conversation a lot. So we're having these conversations about inclusion, we're having these conversations about equity, but why are we having this conversation? And what is the root of this conversation? And the root of that is the historical significance. And many of us in the room hopefully know what that historical significance are. So just two things, like I said, investing in leadership within the community, very, very important because of we're keeping that authenticity there. And then historical significance is also very important within this context, obviously.
Those are great points, and I am intrigued by the notion that communities won't respond to the work that we're doing until we tell them why. Can the why be different depending on where you're coming from? What is the why? And how do you get to that authentic why based on who you represent or the organization you work for or the leadership role that you're in?
I think it's realizing that when we say community, that means so many different things and can mean so many different things and represents so many different types of people. So it's really tailoring the work and the message specifically for each community that you're working with, and investing that time to make sure that if you're working for, you know, for example, I work very closely with the Somali community, and making sure that the message and the information that I'm sharing and I'm disseminating is specifically focused for this specific community, and changing that for the next community that I'm working with. Because I work with various different communities, so just making sure that the information that I'm sharing and I'm tailoring addresses their specific needs. Because when we say community work, it's not just one message, one goal. Like, no, it means different things for different people, and just recognizing that. And I think for Healthier Here, you'll see in the packets that we have this equity impact assessment tool. So it's really for, we worked tirelessly to make this as perfect as we can, because I think it's pretty good. We've invested a lot of time and energy in making this, and it's really a decision-making tool to help folks make those decisions with an equitable lens. So making sure that you're asking yourselves the right question. As you can see, one of them is, which of the following determinants of health equity are impacted, and within the community, what are they? What are those? Because they're different, like I said, for each community. Who could be affected, and what do we already know about them? That's another question. Describe your process for engaging an affected community. So just thinking about again, what are the different social determinants of health that we're dealing with, and what can we do to address those the best way that we can?
So I'll just add on to that a little bit, but Hani was dead on when she mentioned that everybody's different, everyone has different priorities. For those of you who are familiar with logic models or log frames, right, you have your goals that you start with at the end, the big goal you want to accomplish, then you kind of break it down into your objectives, right? Your objectives are sort of the community specific. What is it that we actually need to accomplish in order to, at the end, reach our goal? And if we don't recognize, using terminology again, actually with cultural competency, not cultural blindness, we're not all on the same level, right? If we don't recognize that every community is going to have a different priority, it might be education, it might just be learning about what Medicaid transformation is, and it might be access to bikes and bike helmets, right? It could be anything, but if we don't recognize what those goals are specific to each community, then we can't reach that end goal, which in it sums up to the same. It sums up to this level of equity and that we all have equitable access. But Hani mentioned the tool, and that really kind of leads to our engagement. We have an engagement plan. We have our equity tool. The equity tool is used not just as a catch-all after we've designed our plan. The equity tool is used at the very beginning. All of our project teams had to take this tool as they were proposing their projects, identify the populations that they might be affecting, whether or not they're affecting those positively or negatively, identify all of the details, and then as part of the tool, they actually have to go out and engage with the community and identify what it is the community wants, make sure everything is in alignment, so when they create their implementation plans, that implementation plan is created with input from the community. So we have our implementation plans for Healthier Here are coming up due in the fall, and we're working on gathering all of that community engagement right now so that we can have plans that are actually created by the people that we're trying to create this change for.
And what is Healthier Here hearing from the community? What are the priorities of the communities that you've reached out to? And then sort of an added layer to that is I'm hearing that one community doesn't look like another community, doesn't look like another community, and we are all in King County. So how do we reconcile that, and how is that informing the work that Healthier Here is doing?
Mentioned this earlier, but listening and investing keep reusing the word investing because I really think that's what it is, and investing that time and energy and not, one of our priorities and one of our main goals is having these kind of listening tours and going to the community rather than expecting the community to come to us. And I think that's another really important goal of ours, is utilizing community settings that already exist where the space is already safe, community is already there, and making sure that we're not there speaking, but we're there to listen. We're there to listen to their needs, and we're going to bring those conversations and those voices back, and those voices are what's going to push the work and what's going to drive the work. So listening tours, I think, are really important. Sometimes, especially within our field, we go to events and we talk a lot, but we don't do a lot of listening and active listening, and making sure that, again, those voices and those conversations that you're hearing and those concerns are concerns that you're bringing back, and are concerns that's going to influence the work that you're doing.
And Kennedy, you already kind of reiterated this, and Hani as well, but all the communities are different. One thing I think that we can all agree on is that all of us in this room, most of the communities that we talk to theoretically want that same long-term goal. They want to have equitable access to health, equitable access to education, to economic systems, right? But each community, it looks different for each community, and so that is something that we have to recognize. And I mentioned some want education, some want access to built environments, some want access to healthcare, and it just depends on the community. So it's really impossible to try to sum it up into one.
So just echoing that is so important to listen to community. And in terms of identifying the priorities, that the priorities are different. And before we go out with those community listening sessions and engagement sessions, do your homework. Do your homework. Community has been asked the same question over and over and over. And one of the reasons I think that happens is because we have multiple people trying to tap the community that is already stretched thin. And then we take that information and we keep it within our institution and we put it in a binder on a shelf, or now we put it on websites buried under the resource tab. And it's 184 pages with a sketchy executive summary. And so nobody's really going to use it, right? So one of the things that we are doing at Healthier Here and that we are holding is, and I encourage you all to do this in any of the work you're doing, is do your homework. Find out what community has already been asked and what you still need to learn, and what has and has not been done about what community said before. Now, here's the other interesting little nuance that happens when you do this dance. Because there are multiple organizations and multiple sectors asking community the same thing, when you go out to engage with community, ask these questions, community is going to expect that you've already talked to those other sectors. So you need to be prepared to address that. And even if addressing that means we don't know, be honest about that. We don't know, and we can get the right folks in front of you to answer these questions. I mentioned that it becomes so apparent because I was working with an individual recently, and the individual said, well, I just want community to tell me what to do. Or I'm trying to do this equity work, and I just want people to tell me what to do. And I said, well, here's what you do. Your homework. That's the first thing that you do. And that's the first step toward cultural humility, is recognizing that we have a responsibility to learn things before we even go out and ask questions. We often don't know what we don't know, but we do have an obligation to find out before we go out and ask community.
Another part of that as well, sorry, is not only doing your homework in terms of what the needs are, but doing your homework and understanding who the community is, checking your bias, and checking your privilege. Because I've been in situations and community engagement events where someone who was representing an organization said something a bit problematic, and it made the community completely retract and not want to engage at all. So understand who your community is, understand what the needs are of that specific community, check your bias, and check your privilege.
I think this conversation segues really well into the last question that I want to ask you, and then we're going to open it up for questions from the group. On top of doing our homework, what action can we as individuals take today to advance this work?
Okay, so I'll start. I already mentioned data and organizational structure, but I do think organizational structure and actually doing those root cause analyses, looking back, what is it that causes, I think David, you mentioned we have to look at the disease and not the symptoms, right? We need to actually do those analyses within our organizations, identify what the issues are, and change our organizations to be able to tackle those issues. If we don't, we can be supporting things like ACHs and supporting equity goals and not actually be in a place to make those changes. So that is one thing I think that we need to have done by a group like this. And then the other thing that I had on my notes, which I just put down and then I promptly forgot, sorry, pregnancy brain, was just utilizing things. There are tools out there that are available. Having a couple hour equity training is great. It's not enough. Right, couple hour cultural competency training, great, not enough, right? But there are tools out there that you can use, and you can integrate those into your regular day-to-day processes, equity tools that help you make those decisions using an equity lens. And the more you use those tools, the more you take those trainings, you start to naturally think that way, right? So utilizing the things that are available to you. We have ACHs. ACH one we actually developed from the Healthy King County Coalition's equity tool. They have a Train the Trainer event where they are actually training organizations to then train internal trainers to then train within their organizations. And you can adapt that tool. They're happy to share it and have it adapted to however it works for your organization, right? So make sure that you take advantage of those resources as well.
I would say for me, it's, and these words can make people feel uncomfortable, but decolonizing and dismantling, I think are really, really important in doing this work, because as I mentioned before, there's policies and there's laws and there's regulations that are against the work that we're trying to do, right? There are systems that are put into place and policies that are put into place for us to work 10 times harder than we need to make sure that this work is actually happening and it's happening effectively. So it's decolonizing, it's just destructuring, the dismantling within your own organization, some of those initiatives, some of those policies, some of those regulations, some of those conversations even, because sometimes it starts with the conversation, right? That's then pushed forward. So I think having those conversations, having those uncomfortable conversations, I hate saying uncomfortable because I feel like that's always a thing, right? It's like, well, it's you got to get out of your comfort zone. It's like, it's more than that. It's more than discomfort. It's a lot more powerful. And like we said, like Maria said earlier, people are dying. People are dying because of these inequities, and realizing that the work that we're doing is not easy. And realizing that it's going to take a lot of time, it's going to take a lot of energy, and it's going to take a lot of people to really do this work. So.
Thank you so much. I am going to roam the room if there are any questions. One of the things that comes to my mind as I look for hands is the old anatomy books, where there's a layer of a skeleton, and then there's the muscular system, and then so on and so forth. And what this conversation has brought is another layer to that whole picture. So I want to thank you three for your time today.
Thank you all for your comments and your work, colleagues. Love y'all. So my name is Sybil. I'm with SEIU, and coming from the labor perspective, I'm really curious about an action step that folks in the room could take, looking within your organization and thinking about how you're paying people, how you're promoting people. Is that equitable? And think about that. We see in hospitals oftentimes that a lot of the people who get the lowest pay are brown and black and immigrants. So what can we be doing to change that is something that I would ask to the group. And I'm curious if you all have seen any examples of organizations doing that internal deep dive to see how they can improve equity within how they pay and promote.
So I haven't actually seen it happen. I have heard of it happening often in tech companies and a lot of the kind of up and coming entrepreneurship agencies where the CEO takes a good look at their salary and they decide they don't want to go past a certain percentage of their staff, right? I have not seen that work happening at hospitals, at schools. I've seen, like I said, a lot of EDI, equity, diversity, inclusion councils and committees, people meeting, and I've seen some policies and things changing. You know, schools looking at access to education, and hospitals looking at changing their payment models. But I have not seen that next step in that organizational structure where they actually look at the full staffing and payment models to then change that systematic, in essence, racism is what we're seeing if we look at the data, right? So I haven't seen it, so I can't speak to an effective strategy at this point.
So this is Aaron again. I like the question that we're asking, but you're looking at people who are there responding to some of the issues that we have with institutional racism. But I look in the room and I see a ton of employers. So I see a lot of people who are the heads of their organizations, and I really like to hear from other folks about how you are doing this. And I think that's something that throughout the day I was wondering about is like, what is the personal investment that all of us have in this? So I think we've done a pretty good job laying it out, like who's here. Let's talk about these things. Let's lay out an issue. With, again, the leaders in Medicaid that we have in this room right now, I'd love to see what's happening inside your organizations. Are you changing your payment structures? Are you promoting? Are you investing in minorities and women? People who are there, who can do these jobs, who may not have had that background. This might be the first person in their entire family history and lineage to have this type of job. So, I mean, are there people out there who are innovating within your organizations? And I think that's the magic of this place right here, that we can find out from the people who are those employers. What are the changes that you're making internally? What's that personal investment that you're making?
So, yeah, hi, Diane Sosney with SEIU 1199 Northwest, and just picking up on Sybil's point, this has been a really one of the best quarterly meetings, so much here, and I think I like this thing about how we can not just talk about it, but be actionable. So I have a couple of suggestions of things, and we'd love to partner with our employers on this. But I think it's a misnomer if we just talk. I like David's point about accountable communities of well-being, and maybe we should think about rebranding this group. And I don't know if there are any obstacles to doing that, but I think the point was well made that we can't do the work in silos. I think we also, I don't know how we provide equity around health disparities if our work sites are not accountable communities of well-being. And so I want to insert that and look at how do we, in practical, real ways, make our work sites accountable communities of well-being. And I love this analogy of the authentic conversation. And we see an analogy between when you go to a community asking what they need, and the people closest to the problems are closest to the solutions, those are the frontline workers. And they don't have they're not given the opportunity to rise to the occasion because of structures that have existed for years, institutional racism. I always get a little bristly when I hear the business case. I understand why we talk about that in this context, but there was a business case for slavery in this country for, 100 years. And so we can't, we have to think of new ways to talk about it. But I'm optimistic. even with a lot of pressures coming at us, because I think, I know all of our employers in healthcare, not in healthcare, you have lawyers who advise you how not to get sued, how not to have EEOC complaints, how, have a policy. And again, I think we have to do better than just a policy on the books, that if we have our workforce really reflective of our community, these kinds of connections will happen. So we've actually started to do this work. I've talked about it a little bit here, but we're going employer by employer and actually putting language into contracts to say, let's do this work together. Let's do what Aaron was talking about in terms of first looking internal, looking at what our blind spots are, looking at how we're not seeing because this is the culture and environment we grew up in, and having those authentic conversations, and then moving that with actionable, where's Anthony, measurable, and I think training and we're using training and education for low-wage workers in healthcare institutions to move up career ladders as helping to make a big difference.
Hi, Maura Little, Executive Director here at Cambia Grove, and loved the discussion. Really loved the concept of let's move, let's go. We got to go. People are dying. Totally with you. My question is around, in your work in the community, what programs, what initiatives, what technology, innovation, whatever you might call it, what are things that get you all most excited that you've seen in the past 5, 10, could be last, hour, or it could be last 10 years. The thing that I'm thinking about is the Global to Local initiative that's happening down in South King County. That Gates Foundation came together with the Washington Global Health Alliance and Providence and went in, and what they did was they listened to the community for the first, 2 years. It was 2 years where they came in and thought about this global health technique of let's talk, let's listen first, and then the results that are coming out of that organization are incredible. So I'm curious about, are there things that you see in the community that could be replicated, could be funded, could be promoted, could be any of that to start moving?
One of the organizations that I have been working with for some time now is Global to Local. Global to Local is one of the organizations that I've been working with for some time now, and they, I believe, so we kind of started off at the Health Point Clinic in SeaTac on the first floor. There was a little connectors desk, which was, again, served as like a social service resource where folks would just come up to us, and whether they were Health Point patients or not, we were really helping anyone that would walk through that door. And they have a community health worker program, and I think that's one of the things that I've always really admired about this organization, is that the community health workers are from the community, and they're really leading a lot of this work, and they're organizing a lot of this work, and it brings me so much joy when I see the community being able to mobilize in that way. And that mobilizing happened because folks are, Global to Local is investing within the community, and is investing in leadership, and is investing in initiatives. And I think for me, and one of the many hats that I wear is I'm a graduate student at the School of Public Health. And I think within the public health world, there's this idea of like, we've identified this problem. We're going to create this intervention. We're going to go into the community. We're going to do some of this work, and then we're going to leave. But it's like, are we being sustainable? Are we creating sustainability? Because that's a huge thing, right? It's we're creating these interventions, and we have these initiatives and these programs, but is the community going to be able to do this work after you leave? And I think that's really a conversation that we also need to have as well, is we can promote this, we can promote, these different initiatives and these programs, but what are we doing to really help? So my family's from Kenya, and one of the my grandpa and I always have these conversations about the mosquito nets, right? It's like this, they come into our villages and they give us these mosquito nets and then that's it. But it's like, what else is happening? Are we creating that sustainability? So creating that sustainability and that effectiveness is investing, promoting, and allowing the community to mobilize and to do the work on its own. And I feel like that's really the start, and listening, as I mentioned earlier, really listening. So
to add one more layer, the global to local for this group, one of the things that I continue to talk about in communities when I talk about innovation, that's what Cambia Grove is all about, connecting innovation and the traditional healthcare sectors. It's one of my favorite stories because of that help desk, where instead of asking, how are you feeling, you ask, how are you doing? And then you literally, Dan Dixon from who was with Providence for years would tell, then you would kind of write a prescription for housing or transit or whatever you need, but that language of feeling versus doing had such great impact to the community members that the organization served.
Also, just going off of that, I think realizing that how you are doing from a cultural standpoint means like, I'm telling you how my mom's doing, how my grandpa's doing, how the whole family's doing. It's not just me and my symptoms, but it's me telling you really what's going on in my life. And we had that conversation. We had a lot of those conversations. We had folks who we helped apply for jobs, folks who we were helping with their immigration process, things that we were connecting folks to, transportation resources, housing, really anything and anyone who needed help, we were helping. And I think that's another thing as well, is don't limit the help, don't limit the resources. Understand that a lot of these communities are dealing with more than just one issue. It's more than just one issue that's happening, and I think recognizing that and acknowledging that is really important.
So I have two initiatives off the top of my head, and actually piggybacks onto this. CMAR has a lot of really amazing innovations where they have been integrating with lawyers, where they have changed their entire healthcare model. They changed how they meet with patients in primary care, and they actually talk about, how are you doing? Oh, you're tired, you're having some heart issues. Is it because they're not just asking, well, are you drinking? Are you doing this? What are the clinical questions I need to ask? Right? They're also asking, have you seen your family? Can you go back home to your country to see your family? If you go back home, can you come back to the States? If you can't come back to the States, can you support your family? And then they're providing that pro bono service and bringing in a lawyer to the clinics so that they can essentially then prescribe, kind of how you're saying, that additional resource. They also have food banks and a local community garden and everything else. So I'm seeing a lot of amazing initiatives there. And then also I mentioned earlier, North Sound ACH is doing a lot of connecting with housing and social services and different services that don't automatically fall under our understanding of the healthcare realm. And I found that integration really inspiring as well.
Thank you so much, Haley, because I was sitting here really struggling with whether or not I feel that this is a safe enough space for me to say what I'm going to say, because it is not just listening to the communities of color, to the poor community, to communities experiencing poverty, homelessness, etc. But it's also working with the organizations that have been there for decades. And CMAR is certainly one of those. Seattle Indian Health Board is one of those. International Community Health Services is one of those. And there are numerous other organizations that I can name that are beyond community health centers. And while I love the work that Global to Local has done, I am sorry, but I think part of that is a branding thing for Swedish, for, the Seattle Foundation. And I'm sorry to say that, but the stuff that they are doing, that they've gotten a lot of praise and a lot of press for, are stuff that CMAR, Seattle Indian Health Board, and International Community Health Services has been doing for 45 years and more. And we always have to fight for the braided funding that are available to us. And so I get upset at venues like this where people can really get moved, where organizations can get moved. And Aaron has deliberately asked the organizations here, what can we do? What can you do specifically? And instead, aside from Maura here, everybody answering continues to be the people of color in this room. You know, hey, as much as we have the solutions, the resources are not there. So Haley, thank you for bringing up Seymour. Thank you for bringing up that work. And the work that they're doing is so important in terms of this legal stuff, because all of our communities are in peril right now. When David talks about the census, people are deadly scared. They are scared because it's not just them. They're in blended families of status. Their friends are in blended families of status. These risks are real.
Hi, I'm Annalisa from the OIC, and we are in the unusual position of working right next to one of the most privileged, wealthy, male-dominated white industries in the world, which is the commercial insurance industry. That's where the money is. That's going to support a lot of these initiatives. And I'll tell you, what I'm hearing today is the call to own my power working in that industry. And I feel a little moved because I just came back from a national conference of insurance commissioners. And it was a room full of much older white men, most of them Republican. There were 15 women in the room. That's 50 states. And my experience there was having to tell myself every morning, I belong here. I have something to add. I can shift this conversation. And I know that I'm an older white woman of privilege myself, so I don't have to say it every 10 minutes everywhere I go. But that was a very powerful experience. And I'll tell you how you get ahead in my industry is you adopt that competitive, patriarchal kind of a way of getting ahead. If I want to be an insurance executive, I'm going to need to do that. That's what I've done in my career, and I've attained, but I haven't attained the heights on the commercial side. The regulatory side is where women attain. Regulatory, policy. So it's a very interesting conversation about owning my power as a regulator, talking to the insurance industry. My question today is, how do I introduce this topic in the insurance industry? How can I use my influence from where I sit and Commissioner Kreibler's influence as a statewide elected official to kind of open those doors? And I guess I'm just sharing with you that that is extremely intimidating. It undercuts my authority with that industry to say things like, to be vulnerable, to share vulnerability, and then moreover to say, how are you spending money on this? That is really hard, but I feel the call of it. And I want you to know, in answer to your question, we are looking at our telework policies because I think government is pretty good at speaking outreach and diversity. But I just realized one of the reasons we don't have a lot of people of color working in OIC is Olympia is not a great place to live for people of color. So I've got to do something to invite people to Olympia, and part of it is live home with your community, telework, and come down here once or twice a week. Because I'm not getting the results of my diversity outreach, partly because it's also educational. I work with actuaries and financial examiners. That's not something women and people of color gravitate to. So a million social determinants there. I've said enough, but I really appreciate being here. It's been a tough week. This is very inspiring for me. Really glad to have this finish out my week. Appreciate you all.
Annalise, thank you so much. Thank you for bringing this into this space. And Teresita, thank you for keeping this real in this space, because there is not an easy answer to this. This work is not easy. And this work requires both inside and outside strategies, right? It's working in solidarity to make a difference, to make a change. We often, when you're working inside a place, you can recognize and you can own your power, and you can also own that you may not feel that it's a safe space for you to raise something. That's a very real issue that needs to be raised and called out. And that's why it's so important to partner with community, right? Someone else who can bring that outside perspective to walk with you as you address these issues. Because this work, as I said, is not easy. It's not going to change overnight. It's taken us hundreds of years to get to where we are today. So we're not going to break and deconstruct systems and reconstruct systems in a matter of 6 months according to a timeline that we like to think we can do. But it takes that long-term commitment, that courage, and that starting with, what power do I own? What can I move and influence in this space? And if I can't, what do I need to do to help move and influence in this space?
I wanted to just thank Teresita for really checking us and checking really everyone in the room and acknowledging that, I mentioned earlier that there's organizations, communities, people already doing this work. And I think something that's really a priority for Healthier Here is we're engaging with organizations that are in the community already and that are already doing the work, which makes it a smoother transition. It makes it easier for us to really, and easier for the community, not us, because that's not the priority. The priority is making it as efficient and as smooth as possible for folks within the community. And just going back to my global to local experience, I think for me, it wasn't about the branding. It wasn't about the names. It was about the people's lives I was touching every single day. That's what it was about for me, because we can say that about any organization in this room, right? But for me, it was about those lives, those people that I was helping, and that's what mattered for me personally. Was I was investing in making sure that their tomorrow was a little bit better than it was before they came to us and before they walked through that door. So just recognizing and acknowledging that.
I would love to continue this conversation. It's been the best conversation I've had in a long time, and I don't want to say that we're stopping this conversation. I think we just hit the pause button for time. But Maria, Hani, Haley, thank you so much for being here today.
Yeah. So Bill and I have been over here wrestling about who's going to wrap up, and we really don't need to wrap up because your closing comments about courage, about patience and persistence, about listening. But I also think kind of as strategic leaders, and all of us have these skill sets, we have to learn to step back and let the communities kind of do this work, but be there to support so that there's ongoing assistance. And I loved all the comments about intention. So I do think kind of being that check on intention and really, really important for us to hold these pieces. But wow, talk about like a lot of complexity with what we've just done in the last few hours. Yeah. Bill, you got any other comments you want to wrap that up with? I mean, how do we put that fence around that yard? I mean, this is a lot of work. It's going to be a lot of process. So I do know we are short on time now, and I want to make sure that everybody marks their calendar for our next meeting. Healthier Washington Transformation Learning and Action Collaborative will be October 24th in SeaTac. And that event is targeted towards communities and traditional and non-traditional provider partners to learn about and inspire action around the next phases of our Medicaid transformation implementation. So make sure to mark your calendars. I want to thank everybody today because it really, this is tough work. This is major movement. Cambia Grove, thank you for hosting us. We really appreciate it. Drew is on the phone. Drew, I'm looking up at you in the ceiling. Drew from IHI has been texting and messaging and is aware, I believe he is involved, and so he's been listening, and so we'll be following up with him. Thank you to all of you that participate in HILN and the Communities and Equity Accelerator Committee, especially for helping design today's meeting. Everybody who shared their experiences and the resources to bring this forward. And a huge thanks to the staff, Catherine, Stella, Ryan, Rachel, Kennedy, Chase, and Laura. You guys are amazing about kind of prodding us and pushing us forward. And then Laura is going to follow up by email about the call to action and some of the more demonstrable things that we can keep doing. So anyways, I just want to tell you again, my heartfelt thanks to all of you and for checking us and for keep moving us forward. Erin, your comments, really appreciate it earlier on. And also, I do think we're losing Winfred to a new role. And I want to call out that both Winfred and Sophia and Anthony, the three of you, have really been courageous about kind of moving us in this direction. So thanks to those three. And everybody, return safely to wherever you come from, and we'll see you soon. Transform on. We got work to do.